All right, Cardiac Emergencies Part 2. The American Heart Association has what's called the chain of survival, and if you're a basic life support instructor or have taken a basic life support class, you're familiar with the chain of survival. And the whole purpose of the chain of survival is to identify those things that we need to have in place to give us the best chance of surviving an out-of-hospital cardiac arrest. About 500,000 people have cardiac arrest every year, and about 340,000 of those die outside the hospital. So we can improve their chance of survival by immediate recognition and activation of 911. Early CPR, bystander CPR, improves survival by 40%. Rapid defibrillation, the sooner we can defibrillate a patient, the greater chance they have of surviving. Effective advanced life support, and then integrated post-cardiac arrest care once you get them to the hospital. To have a strong chain of survival requires teamwork. Your chain is only going to be as strong as your weakest link, and for most of us, the weakest link is immediate recognition and activation. On average, patients will wait anywhere from 1.5 to 2 hours before they even seek help. The immediate recognition and activation requires prompt notification of EMS, and that's the responsibility of a bystander. So what we can do to improve that or strengthen that link is to provide education to the community concerning what heart attacks look like, and if they believe that they're having a heart attack, to call 911. Early CPR increases survival by 40%. It can be professional CPR. It also can be trained lay rescuers. It also can be just trained dispatchers that instruct callers who aren't certified in CPR to do chest compressions. Now, early CPR sometimes isn't a problem. In other words, we can get CPR to the patient. The problem is, how good is that CPR? Studies continue to show that we don't do a very good job in providing high-quality basic life support. The more effective your CPR is, the greater chances there are that your patient will survive. So to provide high-quality basic life support, we have to push hard, at least 2 inches in adults, and now the new guidelines request that we push even harder, 2 to 2.4 inches in adults, to allow full recoil. That's when the heart fills up with blood, and to push at a rate between 100 to 120 compressions a minute. Having your hands in the proper position in the center of the chest, lower part of the sternum, compress again at least 100, but preferably 100 to 120 a minute, and spending no more than about 1 second on each of your breaths. You want to minimize interruptions to no more than 10 seconds, because every time you stop CPR, the flow of blood stops immediately. And it takes 7 to 10 compressions to get that blood flow up there where it's associated with getting pulses back. High-performance CPR is the key to increasing blood flow. When we do perfect CPR, we're only moving 20 to 30% of normal blood flow. So we don't move a lot of blood when we do perfect CPR. So it has to be perfect. Now, rapid defibrillation is one of those keys or links in our chain of survival. So as soon as a defibrillator arrives, the more likely that the patient will survive the cardiac arrest. And that's assuming that the patient is in a shockable rhythm. If the patient is in a non-shockable rhythm, it really doesn't matter whether they have a defibrillator or not. At one point, over 50% of all patients that EMS encountered in cardiac arrest were in shockable rhythms. And our save rates in Iowa were about less than 1%. Now, with the ability to provide defibrillators, to carry defibrillators, our save rates are around 26%, but surprisingly, only about 28% of the patients are found in shockable rhythms in the pre-hospital environment. Early advanced care is beneficial, not so much for medications, because medications do not improve survival from cardiac arrest. The focus is on finding and fixing the cause, and the paramedics may be able to find and fix those causes as they transport them rapidly to the hospital. Now, should the patient survive their cardiac arrest, it's really important what occurs in the hospital then. To maintain oxygenation, maintain their carbon dioxide levels, maintain their blood pressure, maintain their body temperature. All those things need to be maintained in the hospital in order to give the patient the greatest chance of survival. And that's what it's just saying here. Keep saturations between 94 and 99%. Don't hyperventilate your patient. So if there's an advanced airway in place, like a King LT or an endotracheal tube, then you would ventilate your patient one breath every 6 seconds. You want to do a 12-lead ECG to see whether or not this person has an acute coronary syndrome, like a myocardial infarction. And if they do, getting them to a cath lab is vitally important. You want to find and fix the cause of the arrest, and those are what we call the H's and T's. And you want to determine where is the most appropriate place to take this patient. And if the patient remains unresponsive, you would consider starting to pack them in ice. Now, EMT provides two links in that chain of survival, and that's early CPR and early defibrillation. When managing cardiac arrest, your role as an EMT is to perform 1 and 2 rescuer CPR. Requires you to begin with standard precautions, glove, gown, goggles, and to use a automated external defibrillator. ALS, if not already requested, should be requested in order to continue the chain of survival. When we ventilate a patient in cardiac arrest, you could use a pocket mask if you're a single rescuer. You could use a bag valve mask with oxygen if you have 2 people, or you could use a King airway as well. The use of a flow-restricted oxygen-powered ventilation device or a demand valve has just really lost favor in EMS. One of the reasons for that is that the air comes out of that demand valve. It's 100% oxygen, which is nice, and that's what was attractive about those devices. But it comes out at 40 psi, 40 pounds per square inch, which is far more psi than what we have on a bag valve mask. Your pop-off valves on a bag valve mask are set to pop off at 20 psi. So if we're using a demand valve at 40 psi, we can overinflate the lungs and cause barotrauma. You need to be able to lift and move these patients quickly with limited interruptions in CPR. You need to be able to suction the patient's airway and to use your adjuncts effectively, like a King LT. You want to also, at some point, somebody wants to interview the bystanders and family members to get a good history. There are different types of AEDs out there. There are semi-automatic AEDs and there are fully automatic AEDs. Fully automated AEDs are something that you might see in an area where they rarely ever use an AED. It does not advise the EMT to take any action at all. What you do is you open the lid. When you open the lid, it automatically turns on. It automatically starts talking to you and tells you to put the patches on the chest. And once you put the patches on the chest, there's no more pushing any other buttons. There's no more charge, shock. The machine automatically identifies the rhythm, the machine automatically charges, and the machine automatically defibrillates. Now, a semi-automatic AED is typically what you're going to see in EMS. The AED is going to advise you to push certain buttons at certain times in order to analyze the patient, in order to deliver the shock as well. Now, monophasic and biphasic refers to the type of electricity. Monophasic electricity, and we may have a few, but not likely. We may have a few old monophasic AEDs around, and that's where a single shock went from one pad to the other. What we use now is called biphasic energy. And biphasic AEDs sends a shock in one direction to one pad and then turns around and sends it back through the other pad. So the heart gets exposed to electricity twice instead of once. The nice thing about biphasic AEDs is that because of that less energy, less damage is actually done to the heart when you defibrillate it. Now, AEDs work because they analyze your rhythm to determine whether or not it is shockable. And if it isn't shockable, it'll tell you no shock advised. There's a variety of different AED protocols out there, but essentially the AED cardiac arrest treatment sequence is to determine the need for CPR, to quickly begin high-quality basic life support, limiting interruptions, pushing hard, pushing fast, ventilating your patient, those sort of things. And then once an AED is available, hooking up the AED and delivering a shock. The rhythms that the AED is going to shock include ventricular fibrillation. And ventricular fibrillation occurs when the ventricles fibrillate, when the ventricles, both the left and right ventricles, quiver. Like a bowl full of jelly. Because the muscle is quivering or fibrillating, there's no pumping action of that muscle. So the blood pressure goes to zero and the patient goes into cardiac arrest. Ventricular tachycardia without a pulse is very similar. You've got a rapid heart rate, sometimes in the 230s, 240s, 300s, that just is so fast that the ventricles don't have time to fill up with blood, and the patient goes into cardiac arrest. Now, we have to coordinate when we hook up the AED. We have to coordinate when we put the patient on a monitor to move them. We have to coordinate all these things, and we want to make sure that we interrupt CPR only when it's absolutely necessary and only for a shorter period of time as possible, preferably no more than 10 seconds. Your patient assessment of a patient in cardiac arrest is to perform your primary assessment. So in other words, when you arrive on scene and somebody's doing chest compressions, that doesn't mean they need chest compressions. You'll need to do an assessment, to check for a pulse, to look to see if they're breathing, or there's any other absent signs of life before you begin your chest compressions. Now, we check for a pulse in the carotid artery in people who are unresponsive because it's a very large artery and it's not likely going to be difficult to find. The pads, you're going to apply the AED pads to the patient's bare chest, so you may have to shave their chest if there's a lot of hair. You also may have to consider the use of a switch or a key or pediatric electrodes or pediatric AED pads in children that are under puberty. You can use the adult pads on children. You just need to make sure that they don't overlap. Now, one person can be providing chest compressions while the other one sets up the AED. You turn it on, you attach the pads to the cables, and then attach the pads to the patient. You stop CPR, push the analyze button. If shock is indicated, it will charge and tell you to push the shock button. Once you push the shock button, the shock is immediately delivered, and you can go right back on to doing chest compressions. Now, every 2 minutes, that AED will tell you to stop, and it will look for that shockable rhythm. And if it finds it, it will charge and defibrillate the patient. Now, some programs would require that you do 2 minutes of CPR before you even hook up an AED, because maybe your CPR will get them back. Now, if the patient is in a rhythm that is not shockable, in other words, the patient is in pulseless electrical activity or asystole, the AED will not shock the patient. It will tell you no shock advised and to continue CPR. When providing CPR, compressions must not be interrupted for any longer than 10 seconds. Compressions need to be at least 2 to 2.4 deep on the adults or on the chest of adults, and at least 1/3 the depth of infants and children. Full recoil is also really important. The rate needs to be between 100 and 120, and you want to switch compressors at least every 2 minutes. If the patient wakes up or begins to move, you're going to know that there's no more reason to give CPR. So at that point, you're going to get a good set of vital signs, administer high flow oxygen, and transport. Again, here a person is checking for a pulse during CPR to confirm effectiveness of compression. I'm glad they put this slide in here because it's highly inaccurate. And what I mean by that is you cannot determine whether or not somebody's CPR is accurate by feeling for a pulse. It's kind of like hitting a hammer with that's full of water. When you hit the hose, hitting a hose full of water with a hammer. When you hit the hose, it may cause a waveform to pulsate through the hose itself, but you're not really moving any water. Some special considerations for AED use. One EMT operates the defibrillator while the other does CPR. CPR must include high quality compression, so the person running the AED certainly would make sure that high quality chest compressions are occurring. You need to be familiar with the AED that you use. You can't touch the patient when the rhythm is analyzing, but as soon as the monitor says shock advised, those sort of things, you can state clear, and when everybody's not touching the patient, you can push the shock button and deliver a shock. Now, it talks about checking the batteries at the beginning of the shift and to carry a spare. Most every single AED does a daily check, a weekly check, and a monthly check. I know, as an example, Philips monitors do a daily check, a weekly check, and at 4 a.m. On a weekend, the AED will fully charge and test the capacitor in the AED. And if there's anything wrong with that, the AED will begin to chirp loud until somebody takes a look at it. So checking batteries is not really something that you need to do, but most AEDs have some sort of visual, whether it be an LED screen that says OK, or whether it be a flashing green light, something that would lead you to believe that the AED is fine. In most protocols, at what point do I leave the scene and start packaging the patient up and move them into the hospital? Well, if you've delivered 3 shocks, which would be about 6 minutes of CPR, and the patient hasn't responded, you need to prepare them for transport and transport them to the hospital. You want to coordinate your care with ALS, so as soon as possible notify ALS. And if the team arrives before you finish your first shock, they should allow you to complete your shock, and then they have 2 minutes before they need to analyze again. You're also going to have to coordinate with others who defibrillate before you arrive. Let the operator of the AED complete the shock before you take over. You also may need to take the first AED to the hospital with the patient so that they can retrieve data from the machine itself. And then local protocols would dictate how you transfer care. Post-resuscitation care, this occurs if the patient has a pulse but is unresponsive. Avoid hyperventilation. Keep the defibrillator on the patient during this period. And reassess frequently, at least every 5 minutes. Most EMS providers aren't performing hypothermia protocol. They aren't trying to make the patient cold unless there's, the ability to do that. If the patient has no pulse, you'll need to do CPR. The AED will give you a no-shock indicated message if the patient's in a non-shockable rhythm. The AED may be prompting you to analyze the rhythm because it thinks there is something shockable. But during post-resuscitation care, ensure adequate ventilation and oxygenation to keep those SATs up, keep their end-tidal CO2 up, I mentioned keep the oxygenation up and keep the end-tidal CO2 where it needs to be as well. Post-resuscitation, we may not have to give 100% oxygen. If the patient has all the oxygen they need, and that would be determined by a pulse oximetry of 94%, and they're not complaining of shortness of breath, and they're not cyanotic, then there's no need to give them oxygen. So you may or may not give them oxygen. Excuse me, post-resuscitation care. It is normal and customary and certainly acceptable to give 100% oxygen during the resuscitation, but once you get them back, you want to titrate that down to maintain SATs between 94 and 99%. Your protocol may also require you to place the patient in therapeutic hypothermia, which is now called targeted temperature management. In other words, we try to get the patient using a variety of different devices cold. They keep them cold for a day and then slowly warm them back up. And when we do this, patients are experiencing a 30 to 50% improvement in neuro outcomes. You also may have issues with lifting and moving the patient as well. If the patient goes back into cardiac arrest, it's probably not a good idea to analyze while you're bouncing down the road with the AED. So have the vehicle stop, begin your CPR, start the CPR. If the AED has been removed, hook it back up, analyze the rhythm as soon as you can, and deliver the shock. And again, you can do this shocking at least every 2 minutes. Now, witnessed arrest in an ambulance, there's no guarantees, but there's a very good chance that you can revive a patient if you witness them arrest. Stop the vehicle and treat this patient like you would any other cardiac arrest if you think that they're close to arresting. But chances are that you are going to get them back if you witness them arrest. Now, if you're in the back of the ambulance all by yourself and the patient arrests, you immediately apply the AED and defibrillate because you witnessed the arrest. Now, once the shock is delivered or it says no shock indicated, then you would go right to CPR. And every 2 minutes, check the rhythm and shock if necessary. Some contraindications of the pads is that if they touch each other, the patient's too small. So if you're dealing with a small child, you want to make sure that the pads don't touch. Another contraindication is trauma with severe blood loss or damage to one or more vital organs, because there's no reason to try to resuscitate somebody who's died as a result of that. And then severe hypothermia. Contraindications also concerning defibrillation. We probably shouldn't defibrillate patients who are soaking wet. You can dab them off with a towel to make them dry, but if they are soaking wet, when you defibrillate, you certainly run the risk of the electricity going on the outside of the body and perhaps into somebody else. It says do not defibrillate a patient if you're touching anything metallic that the other person is touching. And that's, back in the day, that's true. You really just didn't want to, if the patient was laying on a metal strip on the floor, you didn't want to be kneeling on that metal strip either. So, older defibrillators, that might be true, but the newer defibrillators are all grounded well, and that would not be an issue. If they are wearing a nitro patch, you need to remove it before defibrillating or giving them any nitroglycerin, and you want to verbally and visually holler clear before you push that shock button. Now, defibrillation can be performed on patients with an implantable device as well, because if the patient has an implantable defibrillator, obviously it's not working. Or if the patient has an implantable cardioverter or pacer, it obviously isn't working. So you can go ahead and provide defibrillation. You just want to position the pads so that they're not directly over the device. Different types of devices that may be planted that you may come across in the field include a pacemaker, an implanted defibrillator, ventricular assist devices, and cardiac bypass surgeries. Now, quality improvement is the part of the process in the chain of survival where we look at how we can make our systems better. And it involves multiple functions. It involves medical director's involvement with protocol development. It involves initial training of your staff. the maintenance of skills with your staff, case reviews, trend analysis, and all of these will help you strengthen the link in your own community's chain of survival. Maintenance is something that needs to occur on a regular basis on an AED. Some services use the checklist that came with the AED that allows you to write down. It's like a note post-it pad that allows you to keep track of how often the device is being checked and whether or not all the supplies are there and are in good working order and have not expired. Mechanical CPR devices would assist you in providing high-quality basic life support, and there's a variety of them out there, but one of the more popular is the Lucas CPR device. It incorporates the use of an endotracheal tube, which allows you, the Lucas CPR device allows you the ability to manage the airway and do other things without having to worry about doing chest compressions. If you're using a Lucas device, you're obviously going to have to stop CPR just long enough to put it on. But once you get it on, then you want to apply a stabilization strap to keep it on the patient before moving them. And then when the arrest is over, obviously you'll need to turn the device off and power it down. With an auto pulse, that is a load band distributing device, and if you want to see an auto pulse, check with perhaps local systems that may be using them, or you certainly can Google search them as well. Regardless of whether you're using an auto pulse or a Lucas device, you want to provide bag mask ventilation at a rate of 2 ventilations every 30 seconds. Now, after 2 minutes of CPR, you're going to reassess the rhythm as well. When terminating the resuscitation is something that you're going to do once you're comfortable that you've done everything that you can. Once you're comfortable that spontaneous circulation and breathing did not occur or won't occur, or you're comfortable that spontaneous circulation and breathing did occur. You also can terminate resuscitation yourself when you have another trained rescuer to take over for you. You can terminate resuscitation when you're able to turn the patient over to somebody of higher training. If you're too exhausted to continue, if you receive a do not resuscitate order from a physician, you can discontinue resuscitation. Once you start resuscitation, you have to continue it until you've met all the criteria. In other words, you've gone completely through the AED algorithms, and everything that you've tried has failed. If the patient doesn't return to spontaneous circulation after 3 rounds of CPR and ACLS and AED use, then it's not likely that they're going to, and you could consider discontinuation of resuscitation. The state of Iowa does have, discontinuation of resuscitation protocols in place that would help, those people who aren't sure what to do. And that ends our discussion on cardiac emergencies. If you have any questions, you certainly know how to get a hold of me, and I will talk to you soon.